Assalamu alaikum, colleagues. Welcome back. In part 1, we survived the delivery room. We navigated the golden hour, established the airway, and placed the UVC. But the danger is not over. In fact, for the extremely preterm lungs, the battle has just begun. Now, in this video, we have to face the second wave, the onset of respiratory distress syndrome, the risk of apnea, and the threat of ventilator induced lung injury. So, in this part, that is beyond the golden hour, mastering RDS, surfactant, and ventilation strategies. We are going to master three critical interventions: the new standard for surfactant, while Lisa is replacing INSURE, the caffeine protocol, why we don't wait for the first apnea, and number third, gentle ventilation, why volume matters more than pressure. So, here in this lecture, we are going to cover three things: one, two, and three, one by one. In first part, we will learn the method of delivery of surfactant. That is the new standard. That is Lisa over Insure. In second part, we deal with the caffeine protocol for the apnea. And in the third part, we will discuss the ventilation. That is the gentle ventilation. That is volume over pressure control. So, let's dive into the management of the first 6 hours. We have discussed in part 1 the first hour, that is the golden hour for the management of preterm less than 28 weeks. You have settled the baby in incubator on CPAP, but you see that the work of breathing is increasing. Preterm is on CPAP, but work of breathing is increasing. What you can do? You have to deal it with strategy, because you are dealing with the respiratory distress syndrome, that is RDS. In this premature babies, surfactant is deficient and the lung structure is immature. So, do not wait for the X-ray. Gomela reminds us that in the era of early CPAP, the X-ray might look better than the baby feels. So, rely on your oxygen requirement. You have to rely on your oxygen requirement, because X-ray might be delay to show findings. So the new diagnostic update, that is the 2025 update related to surfactant. The question is, when do we give surfactant? Previously, it was prophylactic to give it to everyone. But the 2025 standard is we use early rescue therapy. And according to the European consensus and 2025 guidelines, if a baby less than 30 weeks, means if a preterm which is less than 30 weeker requires FiO2 greater than 30% while on CPAP on 6 centimeter of water pressure, do not wait, give surfactant. Why is there a limit of FiO2 of 30%? Because prolonged exposure to oxidative stress can worsen the baby condition and can lead to injury of the lungs. So we have to act early. So previously, surfactant was given to every preterm prophylactically. But here in 2025, we have to look for two things. That is, if a preterm is less than 30 week and it requires FiO2 of greater than 30% while on CPAP of 6 centimeter of water. So we have to give surfactant. How to give surfactant? So previously we used INSURE, that is intubate, surfactant and extubate method for years. But the problem was intubation requires sedation and positive pressure, which can damage the fragile lung immediately. So previous method was INSURE, that is intubate, surfactant and extubate. But this method requires sedation and positive pressure. So now we have less invasive surfactant administration, that is LISA, less invasive surfactant administration. The 2025 guideline and recent meta-analysis strongly prefer LISA for spontaneously breathing babies. How to use it? You keep the baby on CPAP. You use a thin catheter like an angiocath or a specific surfactant catheter to pass through the cords without removing the CPAP drive. So here we are not intubating the preterm and we are not removing the child from CPAP. This method is for preterm to keep them on CPAP, and through the thin catheter we can give surfactant to the preterm. The benefit of this is you can avoid the physiological drop that happens when you stop CPAP to intubate, and you maintain functional residual capacity. A lot of studies have shown that LISA reduces the combined outcome of death and bronchopulmonary dysplasia compared to standard intubation. So, LISA is preferred over INSURE method in 2025 because of several advantages. First one is it improves the morbidity and mortality. We do not have to intubate the child. No need to intubate. And we can prevent irreversible lung injury as well. So, first one is the new standard method, LISA over INSURE. We have done with it. Now, the second part, that is the caffeine protocol. While managing the lungs, we must protect the respiratory drive as well. This brings us to one of the most important drug in the NICU, that is the caffeine. Previously, we have to wait for the nurse to report an apnea or bradycardia spell. Then we start caffeine. But the new standard for the preterm babies less than 28 weeks, we should give prophylactic loading dose of caffeine. The loading dose of caffeine is 20 mg per kg IV in the first 2 to 4 hours of admission. So here is the change. We are giving caffeine prophylactically to babies less than 28 weeks. So we don't have to wait for the nurse to call us for apnea, bradycapnia spell. The rationale for this is it reduces the risk of apnea of prematurity. So reduces apnea of prematurity. Nelson also explained it that it facilitates successful extubation as well if a child is intubated. So it facilitates successful extubation. Most importantly, it reduces the rate of bronchopulmonary dysplasia and improves neurodevelopmental outcomes as per the CAP trial. So, as per the CAP trial, it reduces BPD rate and improve neurodevelopmental outcomes. So, first one here beyond the golden hour is the child who is on CPAP but their work of breathing is increasing. So we are suspecting RDS and we should not wait for the X-ray to wash out. So we have to rely on oxygen requirement of child. According to 2025 update, if a preterm less than 30 week required FiO2 of greater than 30% while on CPAP of 6 centimeter of water, we should give surfactant. Previous method was INSURE, but less invasive surfactant administration helps in helps to improve morbidity and mortality, and there is no need to intubate the child. The third part of this lecture is about the ventilation. This one is the first one, this one is the second one. Despite CPAP and surfactant, some babies will fail and require mechanical ventilation. If you must intubate, your strategy must change to prevent injury. So, if the child is not improving on CPAP and after the surfactant therapy, and we have to take that child in neonate on ventilatory support, we should be cautious about their lung injury. So, if we are taking any neonate on ventilatory support, we should be worried about barotrauma, that is high pressure. We now know that volutrauma, that is the overstretching the lung with too much volume, is the primary cause of lung damage. So here is the strategy. We are now moving away from pressure control. We move away from pressure control. Now we are using a volume targeted mode, because if the volume is more than what we need, it can cause more lethal injury to the lungs because it overstretches the lungs and damages the alveoli. We usually set a target of tidal volume in between of 4 to 6 ml per kg. So we usually start at 4 to 5 ml per kg. If carbon dioxide is high, we increase the volume, not just the rate. This is because why? Because a baby's lung compliance changes minute by minute. So baby lung compliance changes. If you set a fixed pressure and the lung suddenly opens up, you might inadvertently deliver a massive blowout volume. But volume guarantee autovenes the pressure as the lung improves, so it protects the alveoli. Finally, we must address the fourth trimester environment, the golden hour, and stabilization phases are traumatic for parents. Once the surfactant is in, the caffeine is loaded, and the line is secured. Invite the parents in. 2025 guideline emphasizes family integrated care, that is FiCare. Starting from admission. Even if the baby is too unstable for kangaroo care, right now, hand hugs decrease parental anxiety and stabilizes infant vital signs. But give a clear, honest update. We have helped his lung expand. We have given him medicine to help him breathe. And now we are letting him rest. So that parents know each and every step what you have done to his or her baby. So to summarize the whole lecture, first one, the surfactant. The rule is don't wait for a whiteout. If FiO2 is greater than 30 on CPAP, then administer surfactant. Use Lisa technique to keep the baby on CPAP and avoid intubation injury. So first one, you have to remember FiO2 value less than 30%, give surfactant. And it is given by Lisa method to avoid intubation injury. Second one, give caffeine prophylactically, which is 20 mg per kg. And if the child is intubated, use volume guarantee to prevent Volutrauma. So third one, we are now we are now focusing on volume control rather than pressure control. So ventilation is volume control. And the fourth and the most important is the family integrated care. So family integrated care must know how how their child is being managed, what you are doing with their child, and so on. By mastering these steps, you aren't just keeping the baby alive, you are preserving their future quality of life. This is all about the part 2 of the lecture. If you don't watch the part 1 of this lecture, that is the golden hour period for preterm babies less than 28 weeks, then watch that video as well. These videos are purely for educational purpose and prepared after researching many books and online resources such as Neonatal Guidelines, Nelson Textbook of Pediatrics 22nd edition, chapter 124 and 125, Gomila's Neonatology, European Consensus Guideline on the Management of Respiratory Distress Syndrome 2019 updates, and the Caffeine for Apnea of Prematurity trial, that is the CAP trial, which I have discussed over here. Thanks for watching. If you have any query or if you want any topic which I deliver to you through this lecture series, you can comment that as well on the comment box. Hope so. You will find this lecture helpful. Till the next video. Allah Hafiz.